Hello, let's talk about pancreatitis. What is pancreatitis? Well, it's when the pancreas starts to eat itself through its own enzymes. Because pancreatic enzymes are nuclear warheads of the protein world. They're highly destructive. They can work on lots of different tissues because they work at cutting at certain bases, specifically serines typically. And these proteases don't discriminate. Any protein can fall target to a protease because it's got a very non-specific active site. And so it can lock on to a given amino acid and cut a protein, splitting it in half and rendering it completely useless. And these proteases, they're enzymes, so they're tiny little machines. And as long as they've got the appropriate pH around them and the appropriate cofactors, those enzymes are going to just run infinitely. So a lot of pancreatic enzymes released into the pancreas all at once sure cause some trouble for individual cells. Now, your pancreas normally has a method, a safety valve, so to speak, and that's protease inhibitors. The pancreas makes proteases, but then it also coats the lining of its own interior with protease inhibitors to make sure that autodigestion does not occur. Pancreatitis enters the picture whenever the amount of pancreatic enzymes within the pancreas rises to a concentration that overpowers the amount of protease inhibitors within that organ. And this is going to happen whenever you have an obstruction of the pancreatic duct. Now, an obstruction of the ampulla of Vater counts as an obstruction of pancreatic duct. It's just one step downstream from that pancreatic duct. Let's take a look at that ampulla quickly. I like this cartoon here because it shows you that the common bile duct and the pancreatic duct have their own sphincters. And the two of them combine, merge into one duct at the ampulla of Vater, which is surrounded by a sphincter of smooth muscle called the sphincter of Oddi, and it empties into the duodenum. So if backflow of pancreatic enzymes, like trypsin, for example, if that's what causes pancreatitis, then it's really simple to see, looking at this anatomical cartoon, that any obstruction within the ampulla of Vater is going to be what instigates that backflow of pancreatic enzymes, because they simply have nowhere else to go other than back to where they came from. So the enzyme, the pancreatic enzyme, that's the mechanism of injury, and the obstruction is the mechanism for how do those enzymes accumulate or accrue in the first place. Now let's talk about etiology of acute pancreatitis, different causes, and what they all have in common is that they obstruct the ampulla of Vater somehow, causing a buildup of those autolytic pancrealytic enzymes. Gallstones like to lodge within that ampulla and block up outflow. And small gallstones particularly are the ones that we're worried about, because if the gallstones are big gallstones, well, they'll get hung up in the common bile duct up here, and they won't even make it down to that ampulla of Vater. So if only the common bile duct is obstructed by a stone, well then pancreatic enzymes can go straight into the duodenum unimpeded. Bottom of page 2 introduces you to this vocabulary word, biliary sludge, which is essentially like sand compared to rocks or pebbles, you know, pebbles being actual stones. But, you know, sand is basically tiny rocks, you know, but nobody calls sand rocks. Why? Because it's so small and fine. So that's like biliary sludge. It's the sand analogous to the rocks of actual gallstones. Other conditions can cause ampullary obstruction, which would lead to that backup of autolytic enzymes, which would lead to acute pancreatitis. These include tumors, specifically of the pancreatic head, different parasites. Ascaris lumbricoides is a giant round worm that likes to get up in the duodenum and cause a pressure onto the ampulla of Vater from the outside inwards. And then Clinorchus sinensis, that's the liver fluke. That likes to get up into the liver and into the biliary tree and cause an obstruction that way. Pancreas devisum, that's an anatomical congenital malformation that, you know, is going to clamp down on and occlude that ampulla of Vater. Now we talk about alcohol. The first thing you ought to know is that alcohol upregulates pancreatic enzymes. That's really important because even without an obstruction, if you're making more enzymes than you have enzyme inhibitors, you know, more proteases than you have protease inhibitors, well, that's mild pancreatitis right there. So ethanol increases the capacity of the exocrine pancreas to synthesize digestive and lysosomal enzymes. That's the first thing you ought to know about alcohol in relation to pancreatitis. And then the middle of page 3 covers some more minor points that you're not likely to be tested on, but they should make sense. Hypertriglyceridemia can lead to pancreatitis because, number one, pancreas makes lipase, okay? Number two, lipase cuts free fatty acids off of triglycerides. So the more triglycerides you have in your blood, the more free fatty acids are floating around inside the circulation of your pancreas. Number three, free fatty acids are cytotoxic. And we've seen this before. We've seen this in acute respiratory distress syndrome, specifically following a broken bone or possibly an orthopedic surgery. Patient will get a fat embolus to the lungs. And, well, what's the mechanism of damage? Number one, it's the fact that they've got an artery occluded. But number two, it's the free fatty acids released into the bloodstream in the course of that embolization that are directly cytotoxic to alveolar pneumocytes. So we've seen this lipotoxicity concept. Apply it to the pancreas, it can cause damage there too. Drug-induced pancreatitis. I don't think you're going to get asked about these, but you might on boards. Let's run through a couple of them. Statins, very rare. I did some research. I found a literature review with only 20 individual cases of statin-induced pancreatitis. I don't think you'll get asked about that. Diuretics, you might. And it's because thiazides particularly can raise your blood calcium, and hypercalcemia is associated with the development of pancreatitis. Now, we're going to touch on that hypercalcemia in a minute, but remember that thiazides work on the distal convoluted tubule and that they also induce calcium reabsorption back into the bloodstream, which is part of why we use them to treat some calcium renal stones. And we can prophylax against nephrolithiasis as well using thiazide diuretics. Highly active antiretroviral therapy. If you've done your sketchy, you remembered, what's the one? I'm thinking dadanacine. Our boy Dan, Sir Dan, is sitting at the round table holding a pancreatic sponge. You remember that sketch? King Arthur and the anti-HIV retrovirals. And finally, valproate. Remember your valproate sketch. It's got Pizarro or whatever invader that was, you know, conquistador. And the Incan king comes out to meet him, and they're holding him up. And his throne looks like a GABA cab. And so that's how we remember valproate. It's a GABA channel inducer. It elevates GABA. And then it's also a sodium channel inhibitor. But one of the side effects was one person in that parade procession was holding a pancreas sponge. So that's our sketchy symbol for pancreatitis again. Hypercalcemia of any cause can lead to acute pancreatitis. And this is a really good time to start talking about the role of calcium in pancreatitis before we do. This ERCP procedure is diagnostic and should be benign, but a complication of it is acute pancreatitis, probably because of stricture formation at that sphincter of Oddi that you got to stick your probe into in order to scope out their pancreas and biliary tree. So let's start talking about calcium. This is really important. Obstruction of the pancreatic duct leads to a disruption of calcium homeostasis in acinar cells. Calcium overload of acinar cells, those are the protease-making cells of the pancreas, leads to premature activation of proteases like trypsin and the early onset of pancreatitis. Now, I want to draw your attention to this particular diagram from cell biology that's showing you what's going on in the normal acinar cell. And normally, under physiological conditions, the acinar cell is told to produce proteins and enzymes under the influence of intracellular calcium signaling. Okay. And normal stimulants of acinar cells within the pancreas include two big things, cholecystokinin and acetylcholine, spit out by the vagus nerve. So cholecystokinin is going to get that inositol trisphosphate pathway cranking. It's going to, that second messenger goes and gets your mitochondria and your smooth ER to release some calcium. Same thing with acetylcholine. It binds to an M3 receptor. And the M3 receptor, I know you know this, is a GQ receptor that also participates in that IP3, inositol trisphosphate pathway, that is going to roll some calcium on out of intracellular stores and into the cytoplasm. And that cytoplasmic calcium elevation is what tells acinar cells of the exocrine pancreas to spit out some trypsin into the pancreatic duct. Same page here. Good. So, if you have too much calcium, what that means is you're synthesizing and exporting too much trypsin. There we go. And they've proven this. I read a study from 2000 that said if you hit an acinar cell with a supraphysiologic dose of cholecystokinin, that's going to increase intracellular trypsin activation. And recall that trypsin activation, that's your protease, that's the hub of pancreatitis as a pathology. You can't have pancreatitis unless you don't have that, unless you have that increased proteolytic activity. So sustained calcium overload of acinar cells leads to cell death by apoptosis and necrosis. Necrosis by the enzyme activation. Apoptosis because recall that in any cell, high intracellular calcium, if sustained, is going to activate your, what are they called? Caspase pathways, right? Caspase 3, 8, and 9 that are going to get the ball rolling on apoptosis. So calcium causes cell death from multiple angles. Calcium is also going to cause lysosomes to destabilize and release their enzymes. And when that happens, this lysosomal enzyme cathepsin B will add to the process that's already ongoing by inappropriately activating trypsin early and intracellularly when it shouldn't be. And top of page 4 here is telling us trypsin's normally activated by enteropeptidase in the brush border of the small intestine. It should not be activated intracellularly. It should not be activated inside the pancreas, but when it is, that's how you get pancreatitis. So now we have a good paragraph on alcoholic pancreatitis. It appears ethanol and its metabolites cause contraction of the sphincter of Oddi. And alcohol also stimulates the secretion of protein-rich pancreatic fluid that is prone to form inspissated protein plugs that obstruct pancreatic ducts. So same exact mechanism as a gallstone, just occurring at a little bit smaller level and a little bit upstream. Alcohol makes you make proteins. Alcohol makes the pancreas make proteins. These proteins can aggregate and clump and plug up ducts. There's your obstruction. You try to release enzymes. They can't go out. They have to go back in. Autolysis. A little bit more about cathepsin B cleaving trypsinogen. So cathepsin B is involved in that pathway of trypsin activation. And it's pretty focal, I would say. So recognizing the role of cathepsin B within that whole pathway helps your overall understanding. Probably not testable, but work your way through it. Hyperlipidemia-induced pancreatitis. We looked at this. Free fatty acids are cytotoxic. And finally, we get to a severe implication of pancreatitis, which is the systemic inflammatory response syndrome, or SIRS, which is kind of a precursor to sepsis, because anytime you have a lot of inflammatory cytokines spilled out into your systemic bloodstream, as would be the case with a pancreatitis, then all of the organs throughout your body are exposed to things like TNF-alpha and interleukin-1, and those cytokines are going to instigate vasodilation at the organ level, and vasodilation and inflammation is going to be followed up by radical oxygen species permeation of these tissues, as well as the neutrophilic immune response to damage. And so that neutrophilic response is what can send someone directly into, for example, acute respiratory distress immediately following SIRS. Because you get SIRS, you get a bunch of TNF and interleukins. They go to your lungs. Your lungs have more capillary area and volume than anywhere else in your body. And so all those capillaries become leaky because of the cytokines put into the bloodstream by the injured pancreas. And when they get to the lungs and they cause the lungs to become leaky, well, the lungs pick up a lot of oxidative damage. And so neutrophils go into the leaky lungs to clean things up. And that just leads to a lot of fluid edema in the lungs. And that's your respiratory distress. So if this is going on in multiple organ systems, we're going to call it MODS. So you don't need to know everything about this right now, but as you get into the hospital, especially if you rotate emergency department or ICU or anything, those two terms are going to become pretty relevant and you'll use them frequently. So at the bottom of page 4 is where we begin to branch acute pancreatitis into two separate pathways. You've got acute interstitial pancreatitis, which is involving a lot of interductular fibrosis, but not necessarily a ton of cell damage. And then you've got acute necrotizing pancreatitis, which is severe and which can lead to pancreatic failure and a lot of bad complications. So acute interstitial, you see that, you're thinking mild, self-limiting, barely need to treat it. Acute necrotizing, you're thinking work up for infection. Do we need to debride this necrotic tissue? So let's talk about the pathologic mechanisms and findings in both these types of acute pancreatitis. In interstitial pancreatitis, remember that's our mild form, you're going to see a lot of fat necrosis. And fat necrosis, specifically enzymatic fat necrosis related to pancreatic lipase, is particular to the pancreas. It's the only organ in the body in which you see enzymatic fat necrosis. So if you see that on a question, you know, what type of necrosis is this? Unless you're looking at the pancreas, it's not enzymatic fat necrosis. So lipase takes free fatty acids, and free fatty acids can react with calcium to form soaps. That's called saponification. And you can see the soapy fat calcium deposits on the outside as well as the inside of the pancreas. Here's a couple slides that I had on SIRS. A little bit of a tangent, sorry for backtracking. But SIRS has criteria, right? And so if you look at the criteria, it's basically the same criteria that you use for admitting someone to the ICU. In fact, over 9 out of 10 ICU patients meet SIRS criteria. So it's, for our purposes, a triage tool. And SIRS is basically pre-sepsis. And SIRS becomes sepsis when you confirm the presence of an infection. And then that can continue on down this timeline into severe sepsis, which is its own category, sepsis plus organ failure, and even septic shock, which is sepsis with refractory hypotension. So that's where these definitions are coming from. You ought to recognize them at least. Here's a normal pancreas. You notice it's been pulled out of a cadaver and not much going on with it. It's got a nice tight fascial covering and most of the fat's been cleaned off and it's homogeneously normal. Here's acute pancreatitis. And we start seeing a little bit of fat necrosis on the surface here. I'll try to point it out as best I can. Here's an area down here where you can see just pale tan, baby yellow colored discolorations focally, like little bumps or circles, patches. That's fat necrosis as visible from the outside. Here's another good little chunk. Again, they're just looking like little granules. They kind of look like a furuncle or a carbuncle if you've ever seen one of those on the skin. More fat necrosis right there. And then generally, this organ does not look very healthy. It looks a little bit erythematous and inflamed compared to that one we just looked at. Here's a little bit worse case of acute pancreatitis. This is starting to display some hemorrhaging. You would probably see some hemorrhagic necrosis in this pancreas too, especially down here at the tail. You can tell that it's very red, and this one's been bisected, cut in half. And then up here, that's a really gooey red spot right there, a lot of gooey redness. And then up through there right here towards the head on the top half of the image, you can tell that there's been a lot of vascularization there. And then we also see some fat necrosis on this one. I'll illustrate the clumps in, I think red would be a good color to do it with. Here's a big clump of fat necrosis. You're seeing fat necrosis around the pancreatic duct here in the middle. And it's that pale tan color. Seeing some towards the tail down here. And you're seeing a really big swath of it on this lower half of the image. Basically, all that is fat necrosis of the pancreas. So here's the picture from our SDL. I really like this one, actually. Coincidentally, I keep my SDLs in black and white because it just cuts down on the distractions. You know, when every other sentence is blue or red and every picture has 20 colors in it, you know, it's just not as easy for me to focus. So that's an explanation for that. All of these little pale bumps that you see on the surface of the pancreas in this image on the left are localizations of enzymatic fat necrosis. So you can tell it's got a granular appearance too. And that's clearly not healthy tissue. It's very red, irritated, and inflamed even without that nodular necrosis. On the right is an example of necrotizing acute pancreatitis. So this is the severe variant in which you got to be thinking, is this patient infected? What's their sepsis risk? Because this can turn into sepsis very quickly from SIRS. And so we're looking at this, and the blackened tissue has died and become swollen with blood. That's why it's black, is because there's buildup of hemoglobin inside of it. And that blood just pooled there because there's no more circulation in it. Really, you know, you can't maintain the tone of your blood vessels. And it's a bunch of edema, including red blood cells. So that's an example of hemorrhagic necrosis. If you get shown one of these and they ask, what type of necrosis is it? Just because you see a pancreas and just because they put the word pancreas in the first sentence of the question stem does not mean it's automatically fat necrosis, okay? So look at it. Is it bleeding all over the place? You know, is it blood red? It might be coagulative necrosis, you know, because hemorrhagic necrosis is a type of coagulative necrosis. Oh man, this whole pancreas is gone. And that happens sometimes because symptoms can vary. Pain's the number one symptom for a long time. And so if someone is just like, oh, I'm going to suck it up and deal with the pain, or, oh, I don't have enough money to go to the hospital, then this can develop before they start seeing symptoms other than pain. Here's a histological look at a normal pancreas versus acute pancreatitis. Notice the extreme degree of interstitial fibrosity with that immune cell infiltrate. You can't tell at this low mag if those are neutrophils or lymphocytes, but you got to assume that they're neutrophils, I suppose. And then there's some slight coagulative necrosis going on over here. So yeah, the tissue's a lot looser because of all the fluid edema that's being that's leaking out of cells and of capillaries due to the dilation that's mediated by cytokines like interleukin, TNF alpha, maybe some nitric oxide is going around in here. So that's what's causing edema that's going to loosen this tissue up histologically. That's a good look at pancreatitis initially. Let's get back to this text. Calcium soaps can appear blue microscopically. Just remember that. Necrotizing pancreatitis. We see another histology example here. We've got necrotizing on the right and acute interstitial on the left. And so on the left, this is a mild pancreatitis here. You can see fat necrosis in the upper right triangle of this image. And then you got more fat necrosis actually straight through here in the middle. Basically, only fat necrosis is what you're seeing there. Compared to on the right side here, this is necrotizing pancreatitis. You've got some semblance of normal acini over here, normal exocrine pancreas, but the entire right side of this image is entirely fat necrosis. Again, deposition of calcium gives necrotic fat cells a bluish tinge. I guess I'll look that up. Calcium fat necrosis. Here we go. This is a good image. Go throw this into a slide. Can you tell that this is blue? Can you tell that it's got a pale blue shimmer to it, much like I would say chondrocytes do, right? Like hyaline cartilage is kind of blue. That's the blue that we're talking about here. Okay. So there it is right in the middle. You see this? Fat necrosis, enzymatic fat necrosis. Click, next question. So you can get a hemorrhage within the pancreas in the case of necrotic pancreatitis via digestion of blood vessel walls by the trypsin released secondary to that obstruction, causing the backup of the enzymes. Grossly, large confluent areas of chalky white indurated nodules of fat necrosis and areas of hemorrhage alternate with areas of unaffected tissue. So we looked at a gross pancreas and we saw that. How does pancreatitis present clinically? Well, pain, capital P pain. And it's going to be referred to the back because your pancreas is a retroperitoneal organ. And it's going to be referred because it's carried by visceral nerves that go to your celiac ganglion and then up your greater splanchnic nerve to vertebral levels T5 through T9. And what's really important about the referred nature of that pain is that that pain gets carried through type C nerve fibers, which I don't think those are myelinated. If they are, they're very sparsely myelinated. And this is in contrast to A delta pain fibers that carry pain from the somatic dermatomes, right? Those are going to be larger fibers that send quicker messages. And so type C fibers are tiny, and so they carry slow signals. And when you input a slow signal into your spinal cord, it's competing with other signals from other parts of your body. And so the signal from your pancreas that it's in pain gets jumbled or lost in transmission because it's competing with signals from your duodenum and maybe your T5 through T9 dermatome, you know? Those are all going to the same spot in the spinal cord. So that's why there's a referred pain. Your brain can't tell where it's coming from. Then we talk about Cullen sign and Gray-Turner sign. Understand you might see fever, tachycardia, abdominal distension, but really that pain and the localization of the pain is what's going to get you thinking pancreatitis. You could see Gray-Turner sign or Cullen sign. Let's take a look at those. Here's Cullen sign. It's bruising around the umbilicus, and so I'm not too sure why it localizes here for the pancreas. I do know that if you see this, you're going to be getting a fast exam to assess for blood inside the peritoneal cavity. And this is Gray-Turner's sign. I do understand why you'd see this with a pancreatitis because, again, most of the pancreas is retroperitoneal. And so if you hemorrhage into the retroperitoneal space, it's going to collect at the back along the flank area because it'll go down and back, okay? And so that's your flank ecchymosis. And if you're seeing this, it's really only going to be a pancreas problem or a kidney problem. How else does pancreatitis present? Always said SIRS if it's necrotizing pancreatitis. Severe pain if it's that necrotizing pancreatitis. Again, have a higher suspicion for that. And then SIRS is serious because it can lead into that multiple organ dysfunction syndrome, which is going to be responsible for the majority of deaths accrued by acute pancreatitis as a pathology. Let's talk about complications of pancreatitis. Two types of fluid collection. Understand that when this text says acute peripancreatic fluid collection, that's not a pseudocyst. They're two different things. A pseudocyst has a lining to it, and fluid collection is just basically exudate into the abdominal cavity surrounding the pancreas. So that exudate of fluid into the abdominal cavity surrounding the pancreas is the most common complication of acute pancreatitis. Half of patients get it. They're typically sterile, and again, they don't have a definable wall. And they tend to, well, rather, the lesser sac, the lesser omental bursa, tends to fill up with fluid because that's where the pancreas is. Part of it. And again, it's an exudate, not a transidate, because you've got leaky capillaries throughout the pancreas because of all the interleukins and TNF floating around. And the fluid, if you were to draw some out, is going to contain a high concentration of pancreatic enzymes. So normally these enzymes are kind of deactivated by the fact that they're floating around in the peritoneal cavity. There might be some pH changes or other agents in that fluid that deactivate those enzymes. But if they're not deactivated, you know, having pancreatic enzymes inside your peritoneal cavity is not a good idea because they can chew a hole through maybe a serosal layer of visceral peritoneum or parietal peritoneum. And they can chew up tissue and start an abscess or a perforation elsewhere in that abdominal cavity. So once the enzymes get out, that can lead to a variety of other complications. Now that fluid that pools around the pancreas in the setting of post-acute pancreatitis, that fluid can swell up and press against the duodenum and cause a mechanical gastric obstruction. And I think this is important to take away from this SDL because pancreatic cancer can do the exact same thing and give you the exact same signs radiologically. And what it's going to look like is just a segment of small bowel that's just filled with air. And then the rest of the small gut's fine. You might also see the transverse colon get involved. And you could see what's called this colon cutoff sign whenever you've got air in the transverse colon, but then you get to the descending colon and it stops. It's totally fine. So what's causing that? Inflammation that spreads to the transverse colon via the mesentery, because the transverse colon has a mesocolon, right? And so the pancreas is kind of adjacent to that mesenteric structure. And so if the pancreas is inflamed, then inflammatory cytokines can work their way down the mesentery and get into the transverse colon. And when they do, they're going to paralyze that sucker. It's not going to be able to contract. And when that happens, well, slowly it'll fill up with air. Because what else is it going to do? You know, it's not able to squeeze the air out of it. Okay, because it's paralyzed by the inflammatory state mediated by the pancreas spread through the mesentery. So if that happens, your transverse colon dilates and you get this colon cutoff sign that is highly associated with pancreatitis. And if you saw this same thing, you know, just an area of poofed up bowel, if you saw it maybe up here, like right upper quadrant, and it was tinier, you'd be like, oh, that's a duodenal obstruction, okay? And you know it was obstruction because there's air in the bowel, but it's not really an obstruction as much as it is well, it is an obstruction, but the bowel just can't function because the pancreas is pressing up against it in the case of the duodenum. I hope that was clear because there's like nothing about that in this SDL. So pseudocyst. What is a pseudocyst? Well, it's encapsulated. There's a good picture of it down here. Skip to the picture. Look at how big this thing can get, yo. So these have to be drained very carefully because there's a high risk of infection. And notice it's got a well-circumscribed margin to it. And this right here on the left is a great example of that extra pancreatic fluid collection that we started off by talking about, because this isn't well encapsulated, but it is fluid, and you can tell it's fluid because it's hypodense. This dark patch has the same consistency as the fluid within that pseudocyst. So you can tell it's fluid around the pancreas because right here's your pancreas right there in the middle, and there's all this fluid around it, and so you're assuming there's probably some degree of necrosis involved as well. So that's the difference between what the 1 and 2 on that complications list look like. So that cyst can turn into an abscess. That's bad. Pancreatic necrosis also runs a high risk of infections, and you're going to have to go really broad spectrum. There's also an enterococcus risk, and not a ton of drugs, especially not broad spectrum drugs, work on enterococcus. And so when you detect necrosis, the very first thing you're going to want to do is get an aspiration of that fluid and gram stain it to see if there is indeed a bacterial infection down in there. And if so, what sort of empiric therapy can you throw on it? Pancreatic necrosis, that should make sense. Vascular complications. So pancreatic enzymes chewing up pancreatic tissue, that's pancreatitis. If those enzymes get out of the pancreas and into the surrounding territory because of that fluid exudation, maybe those enzymes start working on blood vessels, and maybe they chew up a little bit of a wall of a blood vessel, and that can lead to a pseudoaneurysm of a medium-sized artery. The splenic artery is most commonly affected. So that can lead to a hemoperitoneum, and they're going to need some interventional radiology. Systemic complications occur during the early phase of severe acute pancreatitis and result from SIRS, because again, SIRS is just one step removed from sepsis, right? And because of that inflammatory response, you're going to be systemically vasodilated, allowing oxidative species to get into tissues and cause some damage, which is going to pull neutrophils into tissues, and those neutrophils are just going to mess things up. So that's how you get something like a respiratory failure. And so why would respiratory failure be the most common complication of SIRS mediated by pancreatitis? Because your lungs have the most capillaries of any organ in the body. Duh. Same thing with the kidneys. They're very highly perfused. You know, there's a ton of microvasculature in there. So you're just increasing the window of opportunity for all of these inflammatory cytokines to cause some damage in that tissue. And then finally, vasoactive substances leading to systemic vasodilation. Obviously, the TNF and interleukins can do that, but damage cytokines in the bloodstream are also going to induce nitric oxide synthase from your medium and large arteries, and that's going to contribute to that peripheral vasodilation. So what lab studies do we have for pancreatitis? Well, nothing really gold standard. The clinical localization of the pain is going to be our first clue, and the imaging is going to be our second clue. Amylase and lipase can help tell us, hey, you need that abdomen axial CT. And amylase and lipase like to go and test questions too. Remember that amylase is also made by the parotid gland, and it's also made by the small intestine, so it's not entirely specific for the pancreas. And then remember lipase as well. You have a lingual lipase when you're a baby. And then other than that, pancreatic lipase is the only lipase I can think of off the top. So that's a little bit more specific than amylase. Hypocalcemia does occur in the majority of patients with acute pancreatitis. And if the patient starts having problems talking because they can't move their jaw muscles, you might want to try to check for Chvostak's sign, which is going to be you're going to tap on their temporalis muscle right there. And if they have a spasm whenever you tap on it, that signifies hypocalcemia. Good images here. Normal pancreas, upper left. We already looked at those bottom two. Acute interstitial pancreatitis in the bottom right. Again, we're seeing a pancreas that's a little bit blown up and grody looking, but it doesn't really have the fluid collection around it like a necrotizing pancreatitis would. Imaging is recommended to confirm the diagnosis. You want to get a CT scan if you're asked that. Acute interstitial is mild. There's a good definition of fat stranding in this STL. It's been brought up a couple times specifically with Crohn's disease, and I don't think there's too nice of an explanation about it in that one. So fat stranding is when the fat within the abdominal cavity starts to get a ground glass appearance, and we've seen ground glass in the lungs. I'm not seeing any good examples of it up here, but that's a good leading point if you want to do some more research about that on your own. And then acute necrotizing pancreatitis have zones of unenhanced parenchyma, which reflect necrosis and fluid edema, as exhibited by the white arrows on this bottom left quadrant. So the whole point of differentiating between interstitial and necrotizing pancreatitis, why would we do that? Well, we want to make a clear distinction between these two categories because one is very highly associated with infection of the pancreas, and the other, interstitial pancreatitis, really is a sterile disease. You cannot really get infection of that pancreas even though it's inflamed until you start to see necrosis of that tissue. So necrotizing pancreatitis, those are the patients that we monitor more carefully and consider sending to the ICU. We're going to do a more extensive workup, and we're definitely going to draw some fluid off of that pancreas if there is any, which there typically is with a necrotizing pancreatitis, and we're going to look at it for microbes. And the sterility or infectious status of a case of pancreatitis also happens to govern the pharmacological and operative approaches that we take to this disease. If someone has an infection, they need antibiotics, obviously. If they don't, they really don't. Antibiotics won't help them. Prophylaxis may be a good idea, but they don't need them. Cases of pancreatitis that have been infected, surgery tends to work a whole lot better for those, or as I should say, you really actually don't need surgery that often in pancreatitis that's not infected. Your body's pretty good at taking care of that itself, provided there's no other source of damage it has to compete with or fend off. So acute interstitial pancreatitis will wrap up acute, 3% mortality compared with 17% in necrotizing pancreatitis. And that bonus 14% in my mind is largely due to infection, number one, and number two, necrosis of the pancreas makes you way more prone to SIRS, which can lead into things like ARDS, MODS, kidney failure, shock. So that was a lot. Let's talk about chronic pancreatitis. Chronic pancreatitis is irreversible and permanent. And when we look at the risk factors or the etiology section for chronic pancreatitis, there's a lot of overlap, with the exception being that gallstones are not a particular risk factor for chronic pancreatitis. However, recurrent acute pancreatitis, that is a confirmed risk factor for chronic pancreatitis, and gallstones can give you acute pancreatitis. So I suppose it's an indirect risk factor, but not a major one. The number one risk factor for chronic pancreatitis is alcohol abuse. And remember, what is alcohol going to do? It's going to induce the production of pancreatic enzymes. And then number two, it's going to the proteins that acinar cells make can clump together and cause small obstructions in the pancreatic ductwork. So alcohol is really giving you pancreatitis through two ways there. Smoking is absolutely linked to pancreatitis. 80% of patients with alcoholic chronic pancreatitis are smokers. Hypercalcemia as well. Recall that calcium is normally the intracellular signaler that gets you to spit out enzymes from your acinar cells. And so if there's too much calcium, there's too much acinar cell activity, there's too many enzymes. That's where the damage comes from. Now, hyperparathyroidism can give you a endocrine hypercalcemia, or it can be acquired. And then a couple of the subtypes of pancreatitis that we'll talk about later can cause a chronic pancreatitis. So the bottom of page 10 is very similar to the pathogenesis section of acute pancreatitis. Understand that alcohol creates protein plugs. Alcohol upregulates proteins from acinar cells. Those proteins clump. They plug up the pancreatic ducts. That's what they want to ask you a question about. They also might want to ask you, where is this going on? Where's the site of the damage occurring? And in chronic pancreatitis, it's within pancreatic ductules. But with acute pancreatitis, it's inside the acinar cell where the damage is actually getting started off. I don't really buy that. I don't know why I highlighted that. I don't think that's a potential question. Understand alcohol makes protein plugs. So alcohol is also cytotoxic. Yes, indeed, but that's not really what sends you into acute pancreatitis. It plays a part in chronic. And then stellate cells. Your pancreas has stellate cells just like how your liver has stellate cells. And in your liver, stellate cells are responsible for cirrhosis and fibrosis of the liver. And fibrosis goes into cirrhosis, remember? And stellate cells are essentially myofibroblasts that typically aren't fibroblasts. So they're just chilling, stacking up vitamin A. And when they're agitated by any injury, they play the role of glue within hepatic tissue, or in this case, pancreatic tissue. So things like TNF and interleukin are going to get stellate cells to differentiate into activated myofibroblasts, which lay down extracellular matrix proteins. And that's where you get the fibrosis in the liver in response to alcoholic liver injury or maybe a hepatitis. And that's also how you get fibrosis in the pancreas. So same exact mechanism for both. Remember, TGF-beta is a fibrogenic cytokine. And we also see that TGF-beta response in M2 macrophages. Remember, you can have M1 or M2 macrophages, and M2s are anti-inflammatory macrophages, and they are associated with propagating the TGF-beta signal to get resident tissue fibroblasts to scar up a wound. Histologically, chronic pancreatitis exhibits varying degrees of atrophy of the exocrine and endocrine pancreatic components, along with calcification and interlobular fibrosis. So the degree of calcification is very, very heavy in a chronic pancreatitis, and it's so heavy to where you could even see a big old calcium stone in the middle of a duct on histology. And that's what we're looking at on the right of page 11 here. And then these are large calcium nodules that have popped up grossly. I feel like you're going to get an image of a gross pancreas. Why? Because it's kind of a hard organ to get accustomed to if you've never seen one before, you know. It looks kind of weird. So here's chronic pancreatitis again. Notice there's normal pancreas to the left of that red line I just drew. And then there's a normal lobe within there. And then there's some normal pancreatic lobes over there. But then we've got this area in the middle here that is just nothing but collagen. I mean nothing but collagen. And that's not a normal pancreas. And then on the left hand here, dilated pancreatic ducts in the setting of fibrosclerotic atrophy. Here in the middle is where your exocrine pancreas glands should be. You can tell they're really not. How does chronic pancreatitis present? Very similarly to acute abdominal pain that radiates to the back, T5 and T9, dermatome, through the celiac ganglion up the greater splanchnic to that region of the thoracic spine. A common cause of chronic pancreatitis is multiple relapsing episodes of acute pancreatitis. And it doesn't necessarily have to be in the back. It could be in the front too. If it presents in the front, you're going to be thinking things like peptic ulcer disease and general bile stones. Now, if your exocrine pancreas is getting wiped out, this is a good point here. You know, if your exocrine pancreas is just getting replaced by blocks of scar tissue, you're going to have a hard time making lipase. And you need lipase to break down lipids in the lumen of your gut. So that would give you fat malabsorption with pale stools. More than half of all patients with chronic pancreatitis develop diabetes due to the loss of complete islet of Langerhans cell mass. And we call this type 3C diabetes. Clinically looks just like other diabetes. That's worth remembering to me. How do we assess chronic pancreatitis in the blood? Well, again, there's no gold standard for this. Amylase and lipase are going to be elevated, but those are non-specific enzymes. Fecal elastase is a good test that's going to help you assess the exocrine function of the pancreas. Imaging might be helpful if you see a sign such as these pancreatic calcifications. Notice they're nodular. They're just little white pebbles down in there. And you don't see them in acute pancreatitis really unless it's acute on top of chronic pancreatitis because it takes a long time for these stones to form, okay? So if you get shown this CT, you know, the question might be, which of the following would you expect this patient to also present with? And so a good sample would be like steatorrhea, you know, fat malabsorption. Maybe they ask you like night blindness, something dumb like that. Fat soluble vitamin deficiency. Or how did they get it? You know, chronic alcohol abuse. Pseudocysts and duodenal or biliary obstruction are well depicted on CT. So that duodenal obstruction, I know this is the transverse colon, but that's going to be what obstruction looks like. Just big, inflated bowel filled with air. What are the complications of chronic pancreatitis? pain's something that patients often have to live with every day, and they can't necessarily even get rid of after a surgical correction of a pancreatitis. So pain control strategies are important to them. Pseudocysts. We've talked about a pseudocyst. It's got a capsule. It's encapsulated. You know, if you see something with a big circle wall around it, it's a pseudocyst. Now, they can get infected. The pseudocysts contain high concentrations of digestive enzymes. That's important to know, because if something pops that pseudocyst while it's inside of you, all of a sudden you have proteolytic enzymes spilled, soaking all of your guts because it's in the peritoneal cavity bin. And that's really bad. And if those enzymes get on an artery, again, the splenic artery, most common, can lead to a bad bleed. Infection is something you always think about. When you see a pseudocyst, you're probably going to start prophylaxis, including metronidazole and maybe ceftriaxone. Mechanical obstruction of the gut, typically the duodenum. It's caused by compression from the pseudocyst. So again, what are you going to see? You're going to see an X-ray with a small bowel that's blown up like a balloon, right? Biliary obstruction could be caused due to stricture formation, and a stricture is a reactive scarring, and the release of pancreatic enzymes within the ductwork is going to be what causes that stricture by damaging tissue. Splenic vein thrombosis, pretty self-explanatory. And pancreatic cancer, understand that pancreatitis is indeed a risk factor that can lead into pancreatic cancer. So the prognosis for patients with chronic pancreatitis, they typically have other things going on, especially if they are alcoholics. So things like atherosclerotic heart disease, valve diseases, respiratory complications, if they're a smoker, tend to be what is the cause of death in these patients. And something else that I've learned is that patients' pancreases can have, you know, large ducts or small ducts, and like big old dudes tend to have big pancreatic ducts, and tiny females tend to have smaller pancreatic ducts. And so the treatment that we use to basically, do we want to do surgery or not, is going to be predicated by the size of the pancreatic duct in the patient. We wrap up this SDL with two special forms of pancreatitis. What you need to know about autoimmune pancreatitis. Two types of it. One of them has IgG4 in the blood, the other does not. One of them stains positive for IgG4, the other does not. So what they're going to ask you about autoimmune pancreatitis is they could just ask you to make the diagnosis based on histology. They could give you the diagnosis and ask you what you would see on histology. Or they could ask you what related disease could the patient develop, because that's included here in the SDL as well. So how do you make this diagnosis? Well, besides IgG, if you look at a slide, type 1 autoimmune pancreatitis has a chronic immune infiltrate, lymphocytes and plasma cells. But type 2 has an acute immune infiltrate, neutrophils. Complications. Type 1 complications include swelling of the salivary glands, sides of your cheeks there, and the orbit and the thyroid, specifically some hyperthyroid diseases like Hashimoto's or Graves'. Those are associated with IgG4-opathies. So if patients' eyes are bugging out of their head, that's called exophthalmos, remember. You're thinking type 1 autoimmune, okay? Now, if the patient's got ulcerative colitis, you're saying that's a type 2 autoimmune. So IgG4 makes the diagnosis. Don't really see anything special in them. Take to some slides and explain them for a bit. Type 1, you don't have any ductal obstruction. So that means that there's your pancreatic duct and there's nothing inside of it. Type 1 again. We've got a lymphocytic infiltrate around pancreatic ductwork, but not inside of it. Type 1 again. We've got a lymphocytic infiltrate around the ductwork, but not inside it. Here's a type 2. We look at this type 2, and here are some ductal cells in the upper right corner of this image, okay? They're cuboidal columnar cells, cholangiocytes essentially, but in the pancreatic tree. And then here are some down at the bottom as well. So everything else that's kind of in the middle of this image is an inflammatory cell. So that's an example of inflammatory cells inside the ductwork. Histologically, that's the only difference between type 1 and type 2. Plus that IgG4 immunostain. So finally, hereditary pancreatitis. This one's easy. You see pancreatitis in a 10-year-old, 12-year-old, hereditary. And it's going to be due to this autosomal dominant inheritance of PRSS1, which encodes serine protease 1. And serine protease 1 gene encodes the protein trypsinogen. So that's what they want to ask you about. That's the majority of cases. These other 3 cases, it's so low yield, it's not worth really sitting down and flashcarding. SPINK1, I dig that just because it sounds funny. So that's going to be serine protease inhibitor kinase 1. I'm just guessing there, but that's probably what it is. So you're going to look at it and be like serine protein inhibitor kinase. Cystic fibrosis gene, they're not going to ask you about that. They wouldn't waste a cystic fibrosis question on that, you know. CTRC, okay. That's it. It's in kids. So basically, you have an gain of function mutation and an overactivation of trypsinogen. So that's just adding to the pancreatic enzyme side of things, and you're not making enough enzyme inhibitor to keep that inflammation tamped down. So that's pancreatitis. Lord, I hate saying the word pancreatitis now. I feel like I just said it 100 times in the last hour, probably 200, you know? Understand the anatomy of the area. Understand there's got to be an obstruction somehow. Understand calcium's at the middle of everything because calcium's what makes your acinar cells make enzymes. And other than that, gallstones in women, alcohol abuse in men. Try to look at some gross pancreatic images and just familiarize yourself with fat necrosis, because I got a good feeling you're going to see a gross pancreas. Other than that, go get it. It's nothing you can't do.